Good evening and welcome. I'm Jeff Spence from the Alumni Relations Office at Thomas Jefferson University, and it's my pleasure to welcome you tonight. This evening, as part of Colorectal Health Awareness Month, Jefferson physician and alumna, Dr. Caitlyn Costanzo, shares the ways you can monitor your colorectal health, preventative steps you can take, and how evolving standards and challenges could impact you. Dr. Costanzo is an assistant professor in the Sidney Kimmel Medical College and serves as co-vice chair for quality in colon and rectal surgery at Thomas Jefferson Hospital. She is a graduate of the medical college class of 2011 and completed both her residency and her fellowship at Jefferson. Dr. Costanzo, welcome and thank you for joining us. Please take it away.
All right. Hopefully everyone can see my screen and hear me okay. Again, thank you so much for having me this evening. And I'm really excited to speak with you tonight and have a good discussion following this talk. So really just for this, I wanted to focus on the must-knows really about colorectal health as it pertains really to colon and rectal cancer. I have no disclosures for my talk. And the learning objectives are going to be to review the epidemiology of colon cancer, to review modifiable risk factors for colon cancer, and then lastly, to give a brief overview of the current screening guidelines for colon and rectal cancer. So I'll start with the epidemiology. Really, depending on what database you look at, colorectal cancer is about the third or fourth most common cancer diagnosed in the United States. This is from the National Cancer Institute of the NIH. Approximately 4.2% of men and women will be diagnosed with colorectal cancer during their lifetime. And it is the second leading cause of cancer-related deaths in the United States in men and women combined. Based on the NCI's surveillance, epidemiology, and end results, or SEER database, there will be an estimated nearly 150,000 new cases of colon cancer diagnosed in 2020, or had diagnosed in 2020. And this represents about 8.2% of all new cancer cases. The estimated deaths will be around 50,000, and this will represent about 8.8% of all cancer-related deaths. Next, I'm going to display some graphs from the NCI SEER databases that will depict the colon and rectal cancer rates over time. So you can see this graph depicted on the x-axis is the year of diagnosis, so from 2000 to 2017. And then on the y-axis, the incidence rates. And for men, it's depicted in green, and for female, it's depicted in blue. So you can see from this graph that the fortunate news is that the rates of colon and rectal cancer has been decreasing over the last 20 years. And this reduction in the number of new cancer cases and cancer-related deaths is a consequence of the current screening program. The rationale for the above is that an adenomatous polyp, as pictured here within the colon, are considered precursors to colon cancer. And through their early endoscopic detection and removal, carcinoma or cancer can be prevented. Prevented is the key word here. And in 2008, the American Cancer Society, the American Society of Colon and Rectal Surgery, and the American Gastroenterology Association all recommended that colon cancer screening begin at the age of 50 for both men and women with an average risk of colon cancer. Now, these guidelines have been more recently updated, which I will touch on later in this talk. However, keeping this age of 50 in mind, I want to show you a few more graphs that unfortunately you may find to be not quite as encouraging. So let's look at colon cancer rates in the 65 to 74 age range. So you can see here from this graph, again, depicting the incidence over time, that the trend for this age population is similar to the previous graph, and the rate of decline is even a bit more precipitous. So this graph is telling us good news. In this age group, we are saving lives from colon cancer-related deaths. So let's change the age range now. Now we're going to talk about the age range of 40 to 64-year-olds. So note that about 60% of this patient population is above the age of 50 and thereby should be getting their screening colonoscopies. So let's look at this trend. So obviously not quite as encouraging as the previous two graphs. Now, you may appreciate a slight downward trend in incidence rates between 2000 and 2011, but in the last decade or so, the incident rates are slowly but surely ticking up. Now, why is this? Is this because less of the 50 to 65-year-olds are getting appropriately screened with their colonoscopy? Or is it because the rates of cancer in the 40 to 50-year-olds is going up, and this increase is diluting the positive trend that we've seen with the older generation? So let's look at one more graph. Let's look at colon cancer incidence rates in ages 15 to 39. I think this graph should be quite the eye-opener, and it really is sobering data, because from 2000 to 2011, the rates of colon and rectal cancer were on the rise in younger individuals. But from 2011 to now, the incidence rates aren't only increasing, but the rate of change is also increasing. In fact, colon and rectal cancer is a leading cause of cancer incidence and cancer mortality among young adults in the United States relative to other cancers. And by 2013, it is predicted that the incidence of colon and rectal cancer will increase by an astounding 124% for persons aged 20 to 34 years old. Now, this to me is a big problem, because the rates of a life-threatening cancer are on the rise. Yet, for this age population, there are no screening initiatives in place that aims to decrease the rates of colon and rectal cancer. So what's going on in this younger population? What is happening that's increasing their rates? So first, let's talk about what we know about young onset colon and rectal cancer. First, it tends to be a more left-sided disease, meaning the majority of tumors are coming and showing up in the rectum or the last part of the colon, the sigmoid colon. Unfortunately, more often, young onset colorectal cancer is actually presenting with metastatic disease. Now, that cannot be fully explained by the fact that they tend to present a little bit later because there's a delay in diagnosis. Honestly, it has to do more with tumor biology, and the young onset colon and rectal cancers just aren't good players. More often, they present with red flag symptoms, including obstruction, abdominal pain, bleeding per rectum. And unfortunately, there's about a 1.5-fold increase in the time to their diagnosis. So oftentimes they present with abdominal pain or they present with blood per rectum. And it's thought that this is due to something such as diverticulitis or hemorrhoids. And it takes time for these patients to get to a screening colonoscopy for definitive diagnosis. And as I mentioned earlier, the young onset colorectal cancers don't really follow similar patterns of molecular tumor subtypes as their older counterparts. So only about 1 in 5, or about 20%, have a pathogenic germline mutation, meaning that there is an identifiable genetic predisposition that tells us that there must be, that there's identifiable genetic predisposition to develop a colon and rectal cancer. So what this tells me is that in 80%, or the majority of young onset colon and rectal cancers, there must be changes related to health behaviors and environmental factors that are impacting the risk of colon and rectal cancer, since only about 20% can be explained by an actual genetic syndrome. And several studies have started to look at certain clinical characteristics that are statistically significantly associated with colon and rectal cancer in young individuals. And identified risk factors include obesity, especially abdominal obesity, elevated triglycerides, elevated blood pressure, smoking, and alcohol consumption. So really, kind of this metabolic syndrome that we see that is responsible for causing, other health-related illnesses. Again, we're kind of seeing them as being risk factors for colon and rectal cancer. But obviously, it's a minority of young people that actually have obesity or have this metabolic syndrome that are actually developing young onset colon and rectal cancer. So there must be something else. And I can tell you that in my practice now, of all the young patients that I am treating, the youngest of which is 30, they actually have no such risk factors at all. Non-smokers, limited alcohol consumption, and they aren't obese and they have normal blood pressure. So there's something that we just do not know. And I think in future years, with future research, there's going to be a more focused effort in identifying individuals who will benefit from a systematic or systemic screening. Because even the young individuals that are presenting to us with signs and symptoms already are more likely to have an advanced stage of disease, and it is likely that only a minority of the young onset colorectal cancers have an inherited syndrome that would be identified by family history alone that would push them to get a colonoscopy sooner. So what we have to do is really to identify better demographic risk factors, certain genetics, constitutional factors, exposures that would make screening initiatives in the younger population more cost effective. But in the meantime, and I'm very passionate about this, there must be a call for a heightened awareness of early signs and symptoms of colorectal cancer that should prompt a diagnostic workup among young adults. Meaning that if a young patient is presenting with blood per rectum and their hemorrhoidal disease doesn't seem to be so bad, that patient, I think, should be referred early to a colon and rectal surgeon to assess for, rectal causes of blood per rectum. And if those causes are not present or something doesn't add up, I can guarantee you that we scope them quite early. So now I'm going to touch on modifiable risk factors for colon and rectal cancer. So the first is definitely obesity and a sedentary lifestyle. So body mass index and colorectal cancer are significantly associated, and there's a increased relative risk about 1.1 per 8 kilograms per meter squared of BMI. And there's a significant negative correlation between colon and rectal cancer and physical activity. And we know that physical activity levels for adults and children have steadily declined over the past several decades. And again, this could be one of the environmental factors that may be explaining why these colorectal cancer rates are going up in the younger generation. Red meat and processed meat consumption also has been shown to significantly increase your risk of developing colon and rectal cancer. And individuals that have had the highest intake of red meat experienced a 20% increase in their risk for developing colon and rectal cancer. So, frying, grilling, broiling meat over at high temperatures tends to release that heme iron content of the meat and tends to produce these nitrogen-based compounds that induce basically DNA damage. So they're acting as carcinogens. So it's my recommendation that the consumption of red meat be limited to 1 to 2 servings per month. So what about fiber? Fiber is the opposite of obesity and red meat and limited physical activity. Fiber is so important. Fiber comes in 2 forms, either soluble, which is in fruits and veggies, or insoluble, which is more in bran-based products. Cellulose, hemicellulose, and pectin are the plant-based type fiber. So what exactly is fiber doing for the colon? So it lowers the stool transit time throughout the GI tract. So what I tell my patients is that it's kind of acting a little bit like a Drano or a Roto-Rooter for your colon. It's really cleaning it out and keeping the lining of it clean. And in doing so, it's reducing really the concentration of intestinal carcinogens because stool is moving through the colon faster. It's also diluting colonic contents. And then fiber has a very symbiotic relationship with the naturally occurring bacteria that occur in our colon, because these bacteria use the fiber to their advantage as their energy source. And the bacteria ferment and produce these short chain fatty acids. And the short chain fatty acids actually have been shown in animal models to induce cell death in colon and rectal cancer. And they also have an anti-inflammatory function for the colon. So fiber is doing us a lot of really great things. And I can't tell you the number of times in my clinic that I recommend to a patient that they start on a high fiber diet or start on some sort of fiber supplement. So high fiber foods, fruits, vegetables, legumes, beans, such as that. Now, the recommended daily amount of fiber intake for men is about 30 to 35 grams. And for women, it's about 25 to 30 grams a day. And sometimes that can be really hard to do just with dietary consumption. So I very often recommend a fiber supplement to be taken daily that just becomes part of one's morning routine. And there are several examples listed here. And one thing I always tell my patients about fiber is that needing fiber equals needing water, because if you take in too much fiber without that water that's necessary to be drawn into the colon, really you're just going to get too much of a constipating effect. And the patients aren't going to like me quite as much. So typically I'll recommend a fiber supplement but also recommend that the amount of water one should be drinking per day is at least about 1.5 liters. All right, so now I'm going to go into some screening guidelines for colon and rectal cancer. And when considering the screening options and timing, I want you to keep this phrase in mind. Prevention is the best intervention. So some of the screening options that I'm going to present here offer detection of cancer and precancerous stage lesions. Now, some of them offer it better than others. However, I don't believe that it should be our goal to stop at detection of precancerous polyps. Our goal should be the prevention of progression of these precancerous polyps to colon cancer. So when should we start screening? And I touched on this earlier in my talk, but basically in 2018, the secondary to new data that came out, as I showed you, on the increased risk of colon cancer in those under the age of 50, the American Society for Colon and Rectal Surgeons changed their screening recommendations, lowering it to age 45 for average risk individuals. Now, at the same time, the American Cancer Society now also recommends that people of average risk for colon and rectal cancer start regular screening at the age of 45. Now, the United States Preventative Services Task Force last updated recommendation came out in 2016, and they still recommend screening for colon and rectal cancer starting at the age of 50. And they actually give this cutoff age of 75 years, which I think is also a little bit outdated. Essentially, for our practice, when I see a patient in my clinic who is at least age 45 and he or she has never been scoped, I do tell them that screening has started at age 45, and I do arrange for them to get their first colonoscopy, really no matter what symptomatology they're presenting with. So the next question is how? How do we screen? And there are several options that have all been accepted and validated by the societies that I mentioned previously. So the first one is a colonoscopy, which we should be giving every 10 years for the average risk individual. The second is a flexible sigmoidoscopy, which is every 5. Virtual colonoscopy, which I'll explain, which is every 5. An enema study every 5, or a guaiac-based, like basically fecal occult blood test every year versus a fecal immunochemical test every year, or one of the newer products, which is the stool DNA test every 3 years. So these are all accepted by the societies as being good screening modalities. And I'm going to explain a little bit about each of these a little bit more. So I'll start with colonoscopy. Really, the use of colonoscopy as a screening and therapeutic modality became widespread in the late 1960s. Colonoscopy has the ability to effectively screen, so detect and remove adenomatous polyps, thereby reducing the risk of cancer development and mortality. Now, the downsides of colonoscopy obviously are that it does require a prep to be done the day or afternoon prior to the procedure, sometimes the morning of. And this tends to be the most difficult part of the procedure for patients. I tell patients often that once they show up for the colonoscopy, honestly, the worst part's over. Now they just get a really nice nap, and when they wake up, they get to go out for brunch or lunch, and obviously they're hungry, so they get a nice meal. Now, colonoscopy, another downside, if you will, is that it is done with sedation. So that does require a chaperone to accompany them to the procedure. It is a procedure at the end of the day. It does come with its risks, and the risks include those from the anesthesia itself. Again, it's not general anesthesia, it's just some twilight sedation, but there are cardiopulmonary risks associated with that. And then the actual procedural risks include bleeding, which goes up slightly if we do an intervention such as a polyp removal, or injuring the wall of the colon as we go around with our scope. Now, either one of those, bleeding or colon wall injury, could ultimately require a second procedure or a surgery to fix. But this happens in less than 1% of the time, and I do tell all of my patients that. And over the past decade, in an attempt to improve really our colonoscopy screening, there have been technical developments with colonoscopic imaging that basically have targeted advancements in polyp detection, including high definition monitors, chromoendoscopy, narrowband imaging, and autofluorescence imaging. And these advancements are a little bit beyond the scope of this talk. I just want you all to be aware that they do exist, and they do help to improve our adenoma detection rate. So the next is kind of like a mini colonoscopy. It's just a flexible sigmoidoscopy. And as this picture shows, basically it's just looking at the very last part of the colon, the sigmoid colon, as well as the rectum. It can go as high as looking at this entire descending colon. And that really just depends on patient anatomy. But the upsides of a flexible sigmoidoscopy are it's an office-based procedure, so no sedation is required at all. Patients come into the office, they get a Fleets enema, and then they can, watch their flexible sigmoidoscopy on the screen as we perform it in the office. Obviously, this is similar to colonoscopy in that it has the ability to see polyps and remove them, albeit this is only happening in obviously the left colon and not the rest of the colon. So you're missing about 2/3 of it. The next, as I mentioned earlier, is what's called a virtual colonoscopy. So this is a minimally invasive, more radiographic option. Basically, it's a fancy CT. And it generates these two-dimensional images that then allow for further reconstruction into three-dimensional images. And it's really the evaluation of both the 2D and the 3D images that allow for any polyp or cancer detection. So the virtual colonoscopy does require a bowel preparation. So you do have to, take at least a half a day off the day before. The day of, there's a catheter that is advanced into the rectum, and the entire colon is basically distended with a CO2 gas. And at the same time, patients are asked to drink a certain contrast. But again, no sedation is required for this at all. And it actually is quite good for detecting colorectal cancer, for advanced adenomas that are greater than a centimeter. They pick up about 94% of them. And they pick up about 90% of adenomas that are between 5 millimeters and a centimeter. So not bad for screening. However, if you were to have a, quote, positive virtual colonoscopy, meaning that we do find a colon polyp, our next recommendation would then be to undergo a colonoscopy. So now let's talk about some of these procedures that really just require sending in a stool sample or collecting a stool sample. So no prep, no sedation, no leaving the comfort really of your own home. The first one is a fecal occult blood test. So that basically is where you take a swab of your stool and you put it on a paper a specialized paper that reacts with a hydrogen peroxidase, and it's either positive or negative for having microscopic blood in it. Now, in order for a fecal occult blood test to be positive, this would require at least 2 cc's of blood loss into the colon a day in order to become positive. Now, this has been improved slightly with what's called the FIT test, or the fecal immunochemical test, which is a bit more sensitive. It uses specific antibodies to detect blood in the stool, and this can detect as little as 0.3 cc's of blood in the stool per day. And again, it's about 95% sensitive for colon and rectal cancer detection. Unfortunately, it's only about 28% sensitive for detecting adenomas or advanced adenomas. And again, when you have a positive fecal occult blood test or a positive FIT test, we then recommend that you go on to get a colonoscopy. An unfortunate statistic is only about 25 to 59% of patients with a positive test actually go on to receive then a diagnostic evaluation. So next we have stool DNA testing. And again, this marketed really as Cologuard. And the stool DNA testing basically relies on the fact that tumor cells and their associated DNA are continuously passed into the stool. And this test is looking for DNA mutations and methylations of certain genes that are commonly associated with colon cancer. While this test not only looks for the DNA, it also does what the FIT test does and basically looks for human hemoglobin, and then it gives you a positive or negative result. Now, I see advertisements, I'm sure as all of you do as well, for Cologuard quite often on television or in many doctors' offices, including primary care physicians or gynecologists, obstetricians. And I can't help but cringe a little bit when I see them, and I'm going to tell you why. And I'll use data from this paper, Multi-Target Stool DNA Testing for Colorectal Cancer Screening, that was published in the New England Journal of Medicine in 2014. And I'll explain with this data why Cologuard testing tends to be a little bit frustrating for me, a provider whose practice really is centered partly around the treatment of and the curing of colon cancer. So what the authors did here is that they did a FIT test, a Cologuard test, and a colonoscopy on nearly 10,000 average risk individuals. So I know this is a busy slide. I'm going to break it down, and I'm going to start to explain these graphs. And I'm first going to ask you to look at graph A, which basically compares Cologuard to FIT testing for the detection of colorectal cancers according to the stage at their diagnosis. And again, on the y-axis is the sensitivity for picking it up. And that was obviously based on the colonoscopy that all of these patients received. And then again, the y-axis or the x-axis is the stage of diagnosis. So what we see here is in light blue, that represents the Cologuard results. In dark blue is the FIT test. So you can see that kind of across the board, Cologuard is not bad for picking up colon cancer. You can see, the rates of, or the sensitivity tends to be between 80 and almost 100% for most of the stages. And it's better, we see, than just the FIT testing alone, especially it's statistically significantly better for stage 1, 2, and for stages 1 and 2. So you can see, again, Cologuard, not terrible for picking up colon cancer. Now, let's take a little bit of a deeper dive by looking at graph B, which I'm going to blow up here. And we'll start by looking at the left half of the graph, which looks at proximal cancers and distal cancers. Again, if you pay attention to the light blue bar, which is Cologuard, not terrible for picking up these cancers, right? They're between 90 and 95%. FIT test a little bit less sensitive, between 65 and 80%. Again, a little bit better for the more distal cancers. But, Cologuard is not bad at picking up these cancers. But now I draw your attention to the right side of the graph, which is where I get a little bit frustrated with the Cologuard. So these are advanced precancerous lesions. So lesions that will become a cancer in a certain matter of time. So lesions that have precancerous changes, large changes, or very large large polyps that are prone to malignant degeneration. So what we find here, if you look at the Cologuard sensitivity for them, so again, in the light blue graph, Cologuard is picking up about 33% of advanced precancerous lesions proximally, and about half of those distal, so more in the left colon, they're getting about half. So that means that basically we're telling patients that if they have a negative test, basically we could be missing between 50 and 66% of the precancerous lesions that are out there. So lesions that are eventually going to turn into a cancer. And remember, colonoscopy is not only finding these lesions, so a lot more sensitive to picking them up, but they're also removing them. And by removing the precancerous lesions, that is what's accounting for the epidemiology graph that we looked at in the beginning of this talk, is that the incidence of colon and rectal cancer is going down in the past 2 decades. So what's happening now as we advance these new tests and we're not detecting 66% of precancerous lesions and we're leaving them in place, and then we're telling the patient to follow up on a repeat test in 3 years, which unfortunately most patients do not do. Are we giving them a false sense of security that their colon is kind of, quote, clean and they don't have a risk for colon cancer? Because what happens when these patients return? Maybe in 3 years, maybe in 5 years, maybe in 10 years, whatever it is, these advanced precancerous lesions, they're not going to be just precancerous at that point. They're going to be cancerous. So, really, when I think of an ideal, quote, screening test for colon cancer, it has to be sensitive. It has to be specific. It should be relatively inexpensive and easy to administer and easily available. But it should also be reducing the incidence of a disease, right? This is what the screening initiatives are for. And maybe the real issue that I have with Cologuard and to some extent FIT testing is really an issue of labeling, that it is screening for colon and rectal cancer, which it's not bad at, but in terms of a preventative measure, it's really not there because, again, it's not detecting those high-grade polyps, and it's certainly not removing them. Colonoscopy is really not only just a screening tool, but it is a preventative tool. And I really don't know where this is going to go in the future. Maybe Cologuard or the FIT testing is going to get more sensitive to precancerous polyps, and that we'll be able to detect them better, and more patients will be referred over for colonoscopy. But what I don't want to see happen as these tests become more popular is us starting to move backwards on really decreasing or moving backwards on our progress of decreasing the incidence of colon and rectal cancer. And again, if we review all of the screening options again, and if we kind of go back to my mantra of prevention is the best intervention, and we consider which of these can detect and remove all adenomas in the entire colon, which is really the precursor to cancer, and be truly preventative, we're really just left with one option, which is the colonoscopy. So then lastly, I just want to quickly touch on who, I keep saying this average risk individual should start at age 45. So who is not average risk? Who should we be looking out for to either screen earlier or more often? So if you have a patient who has a first-degree relative with colon cancer or an advanced adenoma, meaning one that's quite large, basically screening for that individual should start at age 40 or 10 years younger than the age that the relative was diagnosed, really whichever comes first. And with a first-degree relative, your interval for screening should drop from 10 years to every 5 years. If you have 2 or more first-degree relatives at any age, again, this is the same recommendation. They should start at age 40 or 10 years prior to the age of diagnosis. So if there's a sister or a mother or a father that was diagnosed at age 49 with a colon cancer, then any first-degree relative should start their scope at age 39. And again, they should be screened every 5 years. 2 or more second-degree relatives, so an aunt, an uncle, if you have 2 or more of these in your family, then your screening age should start at 40, not 45. It doesn't really matter as much when the diagnosis was for these second-degree relatives, but the screening, again, should drop down to every 5 years. Any personal history of an inflammatory bowel disease, such as Crohn's disease or ulcerative colitis, once you've had the disease for 10 years, rates of colon cancer tend to go up by 1% per year, and they should be scoped every 1 to 2 years. If you have been scoped and you have had a polyp that's greater than a centimeter or more than 3 polyps that are sub-centimeter, your interval should drop to 3 years. And then if you have a personal history of polyps that are small, but between 1 and 3 of them, so your colon looks great but not completely clear, your frequency should drop down to 5 years. And again, all of these non-average risk screening recommendations all are based upon colonoscopy, not the other screening modalities that I had mentioned. So I think I went slightly over time there. Sorry about that, but I really want to thank you for giving me this time to speak. And I hope that I opened your eyes a little bit to, what our new challenges are going forward in our fight against colon and rectal cancer. And also, kind of what frustrations that we're having, within the industry itself, really trying to decrease these rates and keep them, keep going with the progress that we've made. And I'd be happy to take any questions.
Yes, thank you so much, Dr. Thank you. This was a wonderfully informative program and presentation. And for everyone who's attending, we'd be happy to take your questions using the Q&A button located on your Zoom screen. We have a number of questions that have been coming in throughout the program, and we also have some that we received in advance. We'll do our best to get to most of them. I will just make a disclaimer that some of the questions that are very specific to your medical history and preventative care should best be discussed with your primary care physician. So that being said, Dr. Costanzo, our first question asks if you know of any correlation between cervical polyps and polyps in the colon. Does the presence of one increase the chances of the other?
Yeah, that's a great question, and it's actually something that is pretty close to my heart. So cervical polyps and really any sort of like cervical or vulvar or vaginal dysplasia or precancerous changes tend to be related to the HPV or human papillomavirus. And just recently, or, I shouldn't say recently, but over the past few decades, the Society of Colon and Rectal Surgeons have gotten actually quite smart and realized that, the anal canal is quite close to the cervix and the vagina and the vulva. And we found that anal cancer is actually secondary, usually, to HPV. So women who have had abnormal pap smears, cervical polyps that have been removed and have shown precancerous changes should be referred to a colon and rectal surgeon for essentially an anal pap smear to detect if HPV exists within the anal canal. And there are screening modalities in place, which is a talk for another time, which I would be happy to give. But basically, they are out there, again, for the prevention of anal cancer. So a short answer to your question is that there's really not a great association between any cervical polyps or cervical dysplasia and colon cancer, but yes, certainly there are associations between cervical polyps, cervical cancer, and anal cancer.
Thank you for that. Quite a number of questions about pre and probiotics and your thoughts on them in addition to fiber and fiber intake, but your thoughts on pre and probiotics as they relate to gut health.
Yeah, I'm in great favor of the probiotics. Really, anyone that comes to me and asks, like, should I be on a probiotic? Shouldn't I be? I always say yes, because again, it goes back to that healthy gut bacterial load and trying to keep that bacterial load that's normally occurring within the colon as robust as it could be. And again, that kind of goes back to this relationship, like this symbiosis that we see between the fiber and bacteria. Like bacteria love the fiber that we eat. They use it for energy and basically break down products of their fiber utilization, then help our colon cells stay healthy. So I think probiotics plus fiber is a great way to keep your colon lining happy and satisfied. And even, if you look at patients, for example, that for whatever reason, they have an ostomy. Okay. So, and a portion of their colon is kind of disconnected from the rest of their colon. So that portion that's disconnected isn't seeing food. It's not seeing fiber. It's not seeing probiotics. That portion of colon can get pretty sick and pretty inflamed, again, because you're basically starving the lining of that colon by not giving it the fiber that it needs, or by not giving it the bacteria and the fiber that it needs in order to give energy to those colon cells. So oftentimes we have to actually give medicine to that, disconnected colon to keep that lining or mucosa happy. So I'm a big proponent of probiotics, and I'm a big proponent of fiber. I joke with the med students that I should just have a recording of my fiber talk and just play it because it's not uncommon that they hear me say it at least 5 times in clinic. So,
well, at least you're consistent.
Yeah.
Another question has to do with the germline mutation that you mentioned earlier in your presentation. If somebody tests positive for having this mutation through DNA screening or any of those tests, are there other considerations that they should keep in mind?
Yeah, and that really depends on the mutation. So what gene has been identified. The most common genes that we know of are associated with something called an adenomatous polyposis syndrome, where your colon gets hundreds or thousands of polyps. And those patients need to start screening at age 10, believe it or not. If they have a family history of this and they carry the mutation, they start undergoing colonoscopy at age 10. And typically we recommend that they get their entire colon out by age 20. And those patients with that genetic alterations are at increased risk for upper GI cancers, as well as uterine and ovarian cancers. So we do institute screening initiatives for those cancers as well. Another, genetic known predisposition is what's called a Lynch syndrome. And those patients, they are at an increased risk for colon cancer, and they should start screening at age 20. And typically they get scoped every year. And those patients are also at risk for like an upper GI cancer, but also some urinary tract malignancies, as well as the ovarian and endometrial. So there are often screening initiatives for them. So, a big part of my colon and rectal cancer practice is really working with the geneticists at Jefferson, which are phenomenal. And it's, I am constantly referring to them, and they're going over these family histories, and they are, they help to coordinate all the providers that need to be following these patients based on their predisposition.
And I think we have time for just one more question. I will say that for everyone who has questions in the Q&A, what we'll do is we'll share them with Dr. Costanzo, and we'll get back to you tomorrow with some responses to those other questions. But one of our most popular questions currently has to do with some of the conflicting data around the age for recommended testing, and more so the ending of it. The one at 75, but some of your charts go up to 79. And so a lot of questions, just curious about your thoughts on whether colorectal screening is a lifelong endeavor.
Yeah, that I really think the United States Preventative Services Task Force has to revise their guidelines, because I can definitely tell you that I scope beyond age 75. In my opinion, age shouldn't define, the number shouldn't define when you should stop screening. If I see an 85-year-old in clinic that is, otherwise very healthy and active, like there's no reason, in my opinion, and has no contraindications, for getting a surgery, for example. There's no reason, in my opinion, that he or she shouldn't be offered a colonoscopy. If oftentimes, a surgery can be curative for a colon cancer. And if we would recommend chemotherapy, there are some chemotherapeutic agents that are more so recommended to the elderly population. So the choices are out there. So I don't think necessarily you should ever say, oh, you're a stop at age 75. I more so think that if you're physically fit enough and you have no major contraindications to undergoing a surgery, to cure your cancer, then in my opinion, you should be getting the colonoscopy.
Excellent advice. I want to thank you once again, Dr. Costanzo, and I want to thank everyone who joined us and participated in tonight's discussion. We hope that you will continue to get connected with each other and with Jefferson through our new Jefferson Alumni Network. You can register today at alumninetwork.jefferson.edu, and you'll be able to sign up, update your profile, search our alumni directory, and begin connecting and reconnecting with other alumni. We have a number of upcoming events. Tomorrow evening, we have a game watch from the Textile men's basketball 1970 national championship with Coach McGee and the captains of those teams. On Thursday, we have our Emmy Award-winning alumna, Kim Wanup, who will present Setting the Scene, and she will take her experience in Hollywood and tell you how you can translate set decorating to design in your own home or any space. For our OBGYN physicians, we have a CME session next Tuesday rather, and then next Thursday, we have a wine pairing discussion all on Zoom. For these and all of our events, you can visit jefferson.edu/alumni events. Thank you all once again for joining us. Be safe and have a great evening.